Alright, so next we're going to cover enteral nutrition. So this is going to cover the information in chapter 3 of the Advanced MNT textbook, and then it's also going to include just a little bit of a review of some of the other materials that I have assigned for enteral nutrition. So when we're talking about enteral nutrition, it's really important that you understand the difference between an NJ, an NG, a G-tube, a J-tube, a PEG, and a PAGE. So I would just make sure that you review your textbook and understand the insertion and the endpoints. So as you recall, when we talk about an NG tube, we're talking about a nasogastric tube. So that's a tube that's going to go through the nose and terminate in the stomach. An NJ tube is also going to go through the nose and terminate into the small intestine. And then there's lots of different types of G tubes and J tubes, and we're not going to go through the anatomy, nor are you going to be required to memorize the difference between all those different types. We often use a G tube interchangeably with a PEG, or a J tube interchangeable with a PAGE. And there's subtle differences, but there's lots of different endings. So remember, a G tube is just going to be an external connection that goes into the stomach, and a J tube is also going to have that external connection going into the jejunum or another part of the small intestine. So when we're looking at determining the route of enteral access, we're really looking at the anticipated length of time, as well as the individual patient needs, so their level of activity and their preference. So we often learn that we should place an NJ or an NG tube if the patient is needing feeds for less than 4 to 6 weeks. Or we would then look at a G tube or a J tube if we think it's going to be longer than that time frame. And so those are things to consider if you know that you have a really active patient and we're not sure how long they're going to be on feeds for. They might prefer like a G tube or a J tube so that they're not hooked up to a feeding tube the whole time. Other things that might help us determine the route of enteral access is their medical condition or their disease state. So if they're at higher risk of aspiration, we probably aren't going to place the tube into their stomach. Or if they have lots of absorption issues, it actually could go either way. We could place it into their stomach or we could place it into their small intestine. It really depends on what's going on. And then with all of this, we also want to consider surgical options. So a G tube and a J tube would require surgery, which may not be an option for the patient. And then a PEG or a PAGE could be placed at the bedside, but still are a minor procedure and may not be a first-line option for most patients. There is an algorithm for selecting feeding tube placement. As always, you should use your clinical judgment, but I think this is a good place to start. So you'll see that our textbook uses the basis of anticipating the length of feeding time for 4 weeks or less, and then you could just follow that flow sheet. So if we went to over to the left, we anticipate, yes, they need it for less than 4 weeks. Then we would do a naso tube, so that would be either a nasogastric or a post-pyloric. So post-pyloric means just into this small intestine. And so the next criteria here is aspiration risk. So if they're at aspiration risk, they might be a better candidate for an NJ tube. And if they're not at aspiration risk, they might be a better candidate for an NG tube. And then if we went through the flow sheet the other way, yes, we do anticipate that they need the feeds for more than 4 weeks. Then we're looking at doing just a G tube or a J tube, so an enteric tube. And then again, you have the two options, so the aspiration risk, yes or no. I will say that at this phase, though, there's probably more to consider than just the aspiration risk when you're determining if they need a G placement, a G tube placement, or a J tube placement. I don't think that surgical risk is the only thing. You would also want to consider what's going on with the patient, what's going on with their digestive capabilities, and make a decision based on that. And then you would also want to consider if they need bolus feeds or continuous feeds. So Most likely, if you know that you want to do bolus feeds, a gastric tube is going to provide more flexibility. And actually, that's going to be the case anyway. So, a gastric placement would be the preferred placement for most patients, if possible, just because of the flexibility. Another thing to consider is you might not know how long a patient is going to need a feeding tube. I would say that's a pretty common scenario. They come in, they're not doing very well, they haven't been eating, they have some digestive issues. You just have no idea how long they're going to need a feeding tube. So oftentimes a patient might start with an NJ or an NG tube, and then down the road, if we not see that they're not progressing, then they might transition to a G tube or a J tube. But sometimes it takes a little bit more convincing to get a physician to go down that route. And we'll talk about that a little bit later. So when we're looking at NG and NJ tubes, there's a couple of different types of tubes. So the most common tube that you're going to see in your facility is an NG tube. And these are a little bit more rigid. So you can see in this picture here that tube looks pretty large. And they are pretty easy for the bedside nurse to place. They're a pretty rigid tube. And one reason that they're used is because they are pretty wide, so they can place medicines down this tube pretty easily. But they also use these tubes for something called decompression. And decompression is where they can suction. Actually, there's in each hospital room behind the bed, there's a suctioning machine, and it actually can suction out the gastric contents. So if a patient is having a lot of GI discomfort, distress, they use these tubes to suck out those contents. And you'll see the container of contents in the room. So sometimes I'm working with interns or students, and they come back to me and they say, this patient already has a feeding tube. There's nothing about it in the chart. And it most likely isn't a feeding tube. It's most likely an NG tube that's being used for decompression. The NG tubes that we use as a feeding tube are often a little bit smaller, and we'll talk about tube feed size in just a second here. So you'll see the Enteral polyurethane. Those are a more pliable tube that we use for feeding tubes, and they're just a lot more comfortable in the nose, and they're more difficult to aspirate. So you'll see different tube feed sizes based on the patient population that you're working with. So you're going to hear terms called French. So they're labeled in 8 French or 10 French or 14 French tubes. So they say the smallest bore tube, the littlest tube, they actually do have smaller than 8 French. They do have like 5 French, but you'll see like an 8 French tube used in pediatrics. And then a 10 to 14 French tube is more common for adult patients. So one thing to keep in mind is that the smaller the tube, usually the more comfortable it is, but then you're putting formula down a smaller hole. And so the smaller the tube, the more likely it is to get clogged, especially if you're using a thicker or higher concentration formula. So a smaller tube is not always the best option. And oftentimes you won't have a ton of options with the tubes, depending on your facility. And then for the pegs, usually a wider tube, since that's sitting in the stomach opening, we can tolerate a little bit wider of a tube. So a 24 French tube would be more ideal for a peg. I assigned a video that shows how feeding tubes are placed. I think that would be really helpful to watch just so that you can relate to the patient experience. I personally have never had a feeding tube placed, but from what I've heard from patients is that it's pretty uncomfortable. You can imagine somebody threading something up your nose, it tickles, it's uncomfortable. Actually, many of you have probably had a COVID test, and if you had the one where they try to get some of your brain matter out of your nose, you kind of are starting to see what it feels like to have a feeding tube placed. So it's not necessarily really painful. It's just uncomfortable, and it's weird when someone's sticking something up your nose. The most common complaint that I received when a patient had a feeding tube placed is just that their throat was a little sore for a few days after. Um, so in this picture here, they're using magnetic placement with a feeding tube, and you don't actually need an x-ray to confirm the placement. However, this is not an option in all facilities, or I'd say most facilities, but this is something that doesn't exist. So a feeding tube could be placed at the bedside. In a lot of facilities, nursing staff displaces the tube at the bedside, or like a specific designated person comes in and places it. In other facilities, the patient needs to be transported down to like the x-ray area, and they'll place it there, and then they'll take an x-ray to confirm the placement of the tube. Both ways are pretty common. This is, like I said, we're not going to go through the specific differences of all the different types of G tubes and J tubes that exist. There's a ton of different surgical techniques. In my experience, most often they're placing pegs or a peg, but it would again depend on your facility. One thing that most people don't realize is that once you place a G tube or a J tube, it actually does need to remain intact for 4 to 6 weeks to allow for healing. So you might think, this patient needs tube feeds for longer than 4 weeks, let's place this. But you want to also consider that if the patient got better and didn't need it, they would actually still need to keep it in place for that full 6 weeks to allow for healing. So removal of a G tube before the stoma or that hole matures, it actually can result in your stomach or the small bowel falling away from the abdominal wall, and then the bowel contents can leak into the peritoneum, so which is pretty serious and could lead to massive infection. So that's just something to consider when thinking about whether or not a patient needs a G tube or a J tube. And then another thing is that these tubes can actually be used within several hours of placement. There are any research or concrete guidelines as to exactly how soon, but more progressive GI doctors would say, you can use it right away or within a couple of hours. And then less progressive GI doctors might say that you need to wait a full 12 or 24 hours before you can use it, before you can start the formula. If you're running into issues, you can actually refer to the Aspen Safe Practices for Enteral Nutrition. I included that as a resource, an optional resource, and there's a little bit more discussion on when you can start using a G tube or a J tube. For the most part, the G tube and J tubes look similar. So you're going to have some sort of balloon device that holds the tube in place. And then this disc is what is here that's firmly against the abdominal, the outside part. The balloon is on the inside part. And then there's a feeding tube, the tubing. And then there's oftentimes a feeding port and a medication port. And then if your patient has a combination, if they have a peg with a GJ connection, they might have a port for feeding into the jejunum, a port that goes into the stomach, and that's going to be used for decompression. So that's where I talked about the NG tube earlier that helps get rid of stomach content. A lot of patients with digestive issues will have a G port that just helps them decompress and relieve gas or relieve stomach contents. This specific one in this picture has a balloon inflation port, so the doctor can actually go in and adjust the how much air is in that balloon. And then this patient also, this tube has a medication port. So those are just different setups, and it really depend on the GI doctor and what they tend to use. Okay, so the PEG is the most common long-term placement method and actually can be placed at bedside. So this is just another picture again of what that disc or barrier looks like. There's the balloon that holds it in place, and then the tubing as well. Okay, so when we're looking at indications for gastric placement or small bowel placement, so gastric, really the indications for gastric are normal gastric emptying, so they're still releasing their stomach content at a normal rate, and no risk for aspiration. The Aspen guidelines for best practice do state that a gastric placement should be the preferred and initial placement in most patient populations. And so I would always default to that unless there's a contraindication for a gastric placement. Small bowel, so we'll use small bowel and duodenal and jejunal interchangeably, but the indications for that are delayed gastric emptying or gastroparesis, severe reflux. There might be problems with early satiety, and the patient might do better with a small bowel placement, or they have a diagnosis with a significant aspiration risk. So things to look at for risk factors for aspiration and delayed emptying. So if the patient is neurologically impaired, so maybe head trauma, something like that, then they might be at risk for aspiration. If the patient has had severe trauma, they would be at risk for aspiration and delayed emptying. Surgery, they could also be at risk for both. Heavy sedation, so morphine or opiates. So a lot of these refer to a patient in critical care setting. And so the use of gastric placement versus small bowel placement is really going to vary depending on your facility. And I can't say there's a right answer or a wrong answer for these placements. You'll just have to see what's going on. And there's probably going to be a standard. So your ICU might tend towards NG placements, or they might tend towards NJ placements. And it's really just up to the physicians and the dietitian that's been there. Other indicators that might kind of help you lean towards more of an NJ placement is gastroparesis or delayed emptying. Poor oral care in ages greater than 70 years can also be indications that a patient might do better with a small bowel placement. This is from the article that I assigned on J-tubes by Parrish and Bridges, and so they go through even more indications for a patient who would do better with a J-tube. So we already talked about gastroparesis. If a patient has a proximal fistula, you might be able to get access, J-tube access below the fistula, and that could be a great way to feed the patient instead of using TPN. NJ tubes are often used for really severe cases of pancreatitis or chronic pancreatitis if the patient has issues of malabsorption or malnutrition. If a patient has a small bowel obstruction or gastric obstruction, you might be able to place the J-tube below the obstruction. Sometimes you can feed the tube past the obstruction, but most often the doctor is not going to do that, but that is an option. If they're having frequent aspirations from below the stomach, that could be an indication for a J-tube. If they have esophageal dysmotility, so they have a swallowing condition, there's several different swallowing conditions where the muscles no longer work in the esophagus, so that might be a better indication for a J-tube. Another thing is if a patient has a tumor or major ascites from liver conditions, enlarged kidneys, something like that, and that's pushing against their stomach, the patient might do better with the J-tube. And then any history of intolerance of gastric feeding, or if the patient has a history of bariatric surgery and their GI anatomy has been altered, they might not have much of a stomach, and so by default it might end up being a small intestine feeding. So those are just some of the indications. So when we're looking at the advantages of gastric, So if we're thinking about an NG or a G-tube placement, it is more natural. So our stomach is a natural reservoir for ingested nutrients. And as you know, hydrochloric acid is in the stomach, so that can help decrease the risk of infection because it acts as a bactericide to can kill any contaminants. And then of course HCl also helps with nutrient absorption, so it's a little bit more natural feeding into the stomach. And then it also gives us that greater flexibility for intermittent and bolus feeds, so it allows that larger volume that might be beneficial for a patient who's going to be on a tube feed long term. And then it also is just a little bit more natural in a metabolic standpoint. And we know from the research that patients who have a G-tube placed, they meet their nutrition goals sooner, and there's also fewer placement attempts. So it's easier to put the tip of the tube, the feeding tube, into the stomach than it is into the small intestine. Disadvantages of gastric tubes are frequent interruptions. So if a patient is going into surgery or multiple surgeries, they will hold the G-tubes. Whereas, and the reason they do that is just because of the risk of aspiration. So if a patient is flat on the operation table, they could aspirate. And then if you are continuously feeding a patient through an NG tube, you do increase their risk of hospital-acquired pneumonia if they're ventilated, if they're on vent support. So those are some things to think about as far as disadvantage of gastric tubes. When we're looking at advantages of small bowel feeding, so there's decreased risk of aspiration. It's less likely for the contents of the stomach to go back up through the esophagus and cause aspiration. You also would bypass issues with delayed gastric emptying, and some physicians or surgeons will also allow the feeding tube to run during procedures if it's a small intestine placement. Really depends. And then one thing that the research really shows is that the use of small bowel feeding tubes has really decreased the use of inappropriate TPN. So now with this latest research, it's really helped hold off on TPN in the critical care setting, and physicians feel a lot more comfortable starting enteral nutrition into the small intestine. Disadvantages of small bowel feeding tubes. So it is a little bit more costly to place a small intestine feeding tube just because you do need to confirm the location either via x-ray or via that electromagnetic technology that I mentioned earlier. And so if the feeding tube gets dislodged or pulled out, there's just more cost associated with it. And then of course, if you're feeding into the small intestine, you do need to be mindful of volume as well as the osmotic load. So a high osmotic load or too much formula at one time can cause dumping syndrome, and it's a little bit harder to pinpoint exactly what's going on. So with intolerance issues, it's hard to pinpoint if it's the formula, the volume, just the fact that it isn't as natural to feed all of those nutrients directly into the small intestine, so there's a little bit more to figure out. It was previously thought that you can't do bolus or high rate intermittent feeds, so larger volumes or high rates into the small intestine. However, I did provide that assigned article, so this is by Parrish and Bridges, and they've done a lot of research on J-tubes, and by research I also just mean anecdotal evidence from their practice. And the common misconceptions that they found is that JF stands for jejunal feeds, that you can't infuse it over 80 to 100 mils an hour, and they found that that's actually not true. It really depends on the patient and their tolerance level and what's going on. In my personal practice at the hospital facility that I was at, we would not go over 120 or 130 miles an hour. And I found that that is a pretty common guideline that a lot of facilities use. And then once the patient goes home, then they can play with it and figure out what rate they might tolerate. There's a lot of belief that jejunal feeds cause diarrhea, and that's not necessarily true. Again, it depends what's going on with the patient. And then because you don't have digestion and breaking down in the stomach, a lot of people think that an elemental or semi-elemental formula would be necessary. But there's a lot of evidence to show that a standard formula is perfectly appropriate for patients with the J-tube. Okay, let's talk a little bit about the method of delivery. So we talked about the location of the tube, so G-tube, J-tube. Now we're going to talk about continuous, intermittent, and bolus feeds. So when we talk about continuous feeds, typically we're talking about a feed that's running over 24 hours. So in this picture here, I have just one example of what a feeding tube pump might look like. So this is the pump down here. Kangaroo Joey pump is just the name of a pump, and you can see that this is the bag. So one of the bags is for formula, one of the bags is for fluid. So when we talk about a continuous feed, we're talking about using a pump most often, and it's going to run for 24 hours. Some facilities default their continuous feeds to run over 22 hours, and that's just because they know there's going to be some interruptions and stopping, and so they consider that, and they do a shorter 22-hour feed and then a little bit higher of a rate so that the patient still gets the volume that they need. Continuous feeds are definitely the most common option in the inpatient setting or the hospital setting because it's much easier for the nursing staff to manage this. They don't have to worry as much about fluctuation in blood sugars. They don't have to worry about going in and out to stop the feed, to restart it. Nurses have a lot of patients that they're taking care of, and so they can't be in the room constantly. And the research shows that stopping and starting feeds infrequently increases the risk of tube feed clogs, and it also increases the likelihood that the patient won't get their full volume. So I would say it's pretty common that when the tube feeds are stopped, so say the patient wants a shower, so they unhook the feeds, the patient gets in the shower, they finish their shower within 20 minutes, but the nurse is with some other patients, so maybe it doesn't get restarted for an hour or even 2. So those are all things to consider. The other types of feeds that you're going to see are intermittent and bolus. So this really allows for greater mobility of the patient, and so we might see this in some inpatient settings depending on what's going on with the patient. So we might see intermittent feeds, so where the rate's condensed over a certain number of hours. We might see that in a rehab facility where the patient is doing a lot of physical therapy, and so their feeds might run their feeds overnight. And then the patient's not hooked up during the day. We also might see intermittent or cyclic feeds given throughout the day for a patient. So there's some patients who might be going home with the tube feed, and they might prefer their feeds to run over the daytime hours so that they're not hooked up at night. One downside of being hooked up at night is that, you're getting fluid all night long, and so you might have to get up to go to the bathroom a couple of times, and patients don't typically appreciate that. If we know that a patient is going to go home on tube feeds, depending on what's going on with them, we might transition them to intermittent feeds so that they have a break from the tube during the day. There's just lots of different options, and there's not like a set number of hours. And then of course bolus feeds. So this here in this picture is a picture of a syringe that can be used for bolus feeds. You might hear the terminology called infit. Infit is just the type of syringe, and it has a very specific connection. that hooks up with the feeding tube. So there were some, before the syringes were more universal, and there are some issues with administering tube feed formulas into IVs and stuff like that. So they've changed it so that there's a dedicated tube feed syringe that goes into the dedicated feeding port. So that's that photo there is an infant syringe. So bolus feeds, the volume can really be anything, but typically it ranges anywhere from 240 to 480 mils, which is about 1 to 2 cups, and then it is given several times a day. So anywhere from 3 to 6 times a day will be a typical type of bolus schedule. 6 times a day can be pretty cumbersome for a patient. That's 6 times a day of rinsing and washing out syringes or throwing them away. It just creates a lot of waste. And when we think about doing bolus feeds for patient convenience so that they're not hooked up to a feeding tube 24/7, having to do bolus feeds 6 times a day may or may not be inconvenient for the patient depending on what's going on. So that's one thing you want to consider when you're looking at bolus feeds. Okay, so risks and contraindications of intermittent or bolus feeds. So one risk is there is a increased likelihood of diarrhea. So if you're infusing larger volumes of formula, that's a higher osmotic load, and that could increase diarrhea. Another thing, particularly with bolus feeds, is that if you're bolusing into the stomach, then that esophageal junction might lower in tone, and there might be more reflux. And that reflux might just cause discomfort, but it also could increase aspiration. And then another thing is that bolus feeds are not recommended for small bowels tube placements. And I have asterisks there because the article by Bridges and Pear shows that, well, actually you could bolus feed into a small bowel if the patient tolerated it. In my clinical practice, I have not seen tolerance a ton of bolusing into a small bowel, but not to say that you can't do it, it's just going to be dependent on the patient's tolerance. You probably would not do bolus feeds for a patient who is at high aspiration risk. And then I also added in that bolus feeds are not recommended for someone who needs frequent assistance with their activities of daily living, unless they have a support person who can help them with this. And if you think of a patient who's been in the hospital for a while, who has an indication for longer term feeding tubes, they might be a little bit weaker and they might need support with bolus feeds. If you're using a concentrated formula with bolus feeds, it actually can be fairly difficult to use that syringe to kind of pull up that volume and then to push it into the stomach. So someone who has weaker hands or shaky hands, they might actually be able to do the bolus feed with a syringe. So you definitely want to check for that before you set a patient up with bolus feeds, especially if they're going to be living independently. Okay. So just looking at metabolic benefits, so benefits for continuous feeds are actually greater nutrient intake for patients with marginal absorptive capacity. And then continuous feeds actually burn fewer calories via thermogenesis, just because you're providing a small trickle of nutrition throughout the day. This is not really a major point, but it is something to consider. And then benefits of intermittent. Intermittent more closely mimics kind of what normal eating looks like. So several small meals throughout the day would be more in line with intermittent feeds. And so then you have that nice cyclic elevation of insulin levels. And insulin plays a pretty key role in building protein mass. And so you have more natural insulin levels and more natural protein synthesis. So through that, they've seen improved albumin levels, improved transferrin levels, and then just better intestinal mucosa, resulting in improved protein mass. Despite this research, though, you're going to see more typical continuous feed, more for the convenience of better blood sugar control, as well as convenience for nursing staff. Okay, we're not going to go into detail about disease-specific formulas. I assigned an article or a couple pages of a chapter from the Aspen Core curriculum that goes through the research on disease-specific formulas. The consensus currently is that disease-specific formulas are not necessary, unless in certain situations. So we would usually default to using a standard formula unless there is an indication that a specialty formula is needed. I will point out that renal formulas are probably the most common specialty formula that is indicated. These formulas tend to be higher in protein and then lower in the renal electrolytes, so lower in phosphorus, potassium, and sodium. And then they're also calorically dense, so they're concentrated because oftentimes renal patients on dialysis need some sort of fluid restriction. There are also renal formulas that are low in protein. So if a patient has like stage 4, stage 5 kidney disease, they would need a lower protein formula. So there are renal formulas that are low in electrolytes and low in protein. So I would say renal formulas would be more indicated if a patient is renally compromised. There are also specific pulmonary and liver specific formulas. The research is not necessarily convincing for either of those options. Kind of the consensus is that some of these specialty formulas are designed by formula companies just to have another product out there. These products tend to be higher in cost, and so the research isn't always there to support these specialty type formulas. There are also specific diabetic formulas that are lower in carbohydrates and higher in fat. Again, the research does not support use of a diabetic formula. However, in clinical practice, you might see physicians who really want to use a diabetic formula, or if you have a patient who there's a lot of issues controlling their blood sugars, that might be an option why you would choose a diabetic formula as well. And there are some trauma or wound healing formulas that are really high in protein, and some of them have arginine and glutamine to help support wound healing, and we'll look at the research in those when we talk about wound healing and trauma. Okay, so there are lots of different types of tube feeding formulas, and I've included a couple of different lists. So in your resources for the week, I have the link to formulas by Nestle and formulas by Abbott. So those are the two major players when it comes to tube feed formulas, and there's dozens of formulas. And they're broken down into the disease state. And then there's a lot of formulas, like you have Replete, you have Replete with fiber, things like that. And so you probably won't have access to every single formula out there when you're in your clinical rotation. At some smaller hospitals, maybe you will only have 2 or 3 options. And then at some larger facilities, you might have 10 or 12 formula options. So I've just listed them here just as a reminder that there are specialty formulas that exist, and they may or may not be indicated prior to trying a standard formula. And then the nutrient content is listed as well. This is just for reference. And then the Enteral guides I posted in D2L in a couple of different ways. When you're working on problem sets, sometimes it can feel overwhelming looking at all of the different formula options that are offered by Abbott and all of the different formula options that are offered by Nestle. So you might consider just choosing one main brand and going with that, and that's totally fine. Okay. And then there's an algorithm for determining tube feeding type. So you could utilize the algorithm as well as your clinical judgment in the research to determine if a disease-specific formula is needed. So I mentioned disease-specific formulas, but there also are other types of formulas that are still similar to a standard formula. So there are more concentrated formulas. So a more concentrated formula would be like a 1.5 or a 2 calorie per ml formula. So those might be indicated in patients that need a fluid restriction, or if they have tolerance issues. If a patient has impaired digestion or malabsorption, an elemental or semi-elemental formula might be indicated. And then if they have major metabolic stress or wound healing needs, an immune type formula might be indicated. So again, there's those types of formulas, and then there's just disease-specific formulas like liver, pulmonary, and diabetes formulas, which may or may not be indicated. Okay. One thing that I felt like the textbook didn't cover very well is enteral modular products. So there's tons of tube feed formulas out there, but say you calculate your patient's calorie needs and their protein needs, and there's not a formula that's getting what you need. Say the patient has fairly low calorie needs and really high protein needs for wound healing. There might not be a perfect formula, and they might need additional protein. So there are several different products out there that provide additional protein that can be put into a feeding tube. So there's Juven, and you can see on the label there that Juven has arginine and glutamine. It's often used for wound healing. We'll talk about the research later, but that product is used for protein. Binaprotein is a protein powder that's commonly used for tube feeds. And then Prostat, there's a ton of different ones. Prostat is just the picture I grabbed, but Prostat is a liquid protein that can be used as well. So one of the positives of these products is that they obviously provide protein for the patient, but they are difficult for nursing staff to use. So if you're in the ICU, they're pretty used to using these types of products, and they'll definitely administer them. If your patient is just on the medical floor and they are not as used to feeding tubes, these protein modulars might be a little bit more challenging for them to use. So if you write an order that says provide 1 packet of binaprotein 6 times a day, the nursing staff is probably going to be a little bit annoyed. That's a lot of work for them. And it also increases the likelihood of a tube being clogged. So I always do my best to choose a formula that I think will be as close to the patient's needs as possible, even if I go over a little bit on calories. And then if I really can't find a formula that's going to meet their needs, then I would go in with adding a protein supplement. And it's really just going to depend on what your hospital facility carries, who they have a contract with. So it could be a liquid option, it could be a powder option. You might have the option of both. There are also fiber products, so similar situation. Say a patient needs a really particular formula, and the formula that your hospital carries doesn't have the fiber version, or the patient has fiber needs. Fiber supplements are also an option, and they're going to be administered the same way. So you might write an order for fiber to be added 3 times a day. So that's an option as well. Okay. Another thing to consider is when do we need to initiate enteral feed. So in most cases, enteral nutrition does not need to be initiated for a well-nourished patient until they've had no or inadequate intake for 7 to 14 days. Some facilities have adapted this to 7 to 10 days. So this could also include the period of time before the patient came into the hospital. And this is hard for people to implement because they're thinking this patient hasn't had any food for 5 days, we have to do something. But if they're relatively well nourished and they just have an acute illness, they can go 7 to 14 days without food. We would be giving them IV fluids and hydration, but they wouldn't necessarily need nutrition. But if they're higher risk, um, they are severely malnourished, they have other medical conditions, they might need enteral nutrition sooner than that 7 to 14 days. And then, of course, in certain conditions where we know that the patient is critically ill or has a more severe illness, we will start the enteral nutrition within 24 to 48 hours. So if they're an ICU patient, we'll start it within 24 to 48 hours. If they're a coma, if they have a severe medical condition and we know that they're going to need enteral nutrition for a little bit longer, even if it hasn't been 7 to 10 days yet, we're just going to start the enteral nutrition because they have an anticipated need that's going to last for longer than those 7 to 10 days. Again, this is really going to be hospital facility specific, but these are things that you can start to think about as you're going into clinical practice. Okay, and then save this for your clinical practice. I think this is a really handy chart table to use. These are the contraindications for enteral nutrition. So, severe bowel syndrome, severe short bowel syndrome. So if they have less than 100 to 150 centimeters remaining of their small bowel with no colon, or less than 50 to 90 centimeters, and they do have a colon, that's going to be considered severe short bowel syndrome, and they're probably not going to do well with enteral nutrition. If they have a severe malabsorptive condition, severe GI bleed, a distal high output fistula, or an ileus, those would be contraindications for enteral nutrition. If you're not sure what a fistula or an ileus, what they are, you should look them up. So that would be good practice for clinicals. If you're not sure what the terminology is, look it up so that you know what it is. Other contraindications would be intractable vomiting or diarrhea that doesn't improve with medical management. Those would be contraindications for enteral nutrition. If a patient is vomiting a ton, they can actually vomit out the feeding tube as well, and it won't be effective. And then obviously if they have severe diarrhea and then we're putting a formula in and medicine isn't helping with the diarrhea, then parenteral is probably a better option. If they have a mechanical obstruction or their GI tract can't be accessed, then we're not going to use enteral nutrition either. Okay. So let's talk just briefly about complication management. We're not going to go into this in too much detail. You're often going to see complaints of nausea and vomiting that are going to be blamed on the feeding tube, but they may not be related to the feeding tube. So sometimes there might be gastric retention, and that can be improved by providing isotonic feeds. Nausea and vomiting can be caused by rapid infusion of a hyperosmolar formula. So something that you could do is you could try reducing the rate of the feeding for a day or two and see if that helps. And then, of course, if the patient is vomiting, then you have two options. One is to stop the feeds, and two is to consider changing the formula. Nausea and vomiting can be caused by a fat content, although I say that this is less common. I don't see this a ton. And occasionally the smell of the formula, particularly with patients who are on long-term feeds, can cause nausea or vomiting as well. So elemental formulas tend to be a little bit smellier than a standard formula. Abdominal distension can also be a complication of enteral feed. So possible causes could be like a rapid bolus or intermittent feed, especially if it's cold. Usually doing formula at room temperature is better tolerated. And then, sometimes patients who are on bolus or intermittent feeds use the cartons of formula that are similar to like a boost carton, and they might just use half of it for a feed, and then they put it in the fridge. And so if they're noticing that they're not tolerating the cold formula, they can set it out and let it come to temperature, and then use it within 2 hours. And then, of course, continuous might be a better option if a patient is having frequent abdominal distension. And then other causes of abdominal distension are absorption, delayed gastric emptying, and then if there's an onset of sepsis, that could cause abdominal distension as well, and that wouldn't be related to the feeding tube. Okay, so some complications related to delayed gastric emptying. So, gastroparesis is probably one of the more common ones, and that could be related to diabetes, but it also could be an injury to the vagus nerve through surgery or trauma. Other common causes of delayed gastric emptying are medications, so painkillers like opiates can cause delayed gastric emptying. So if your patient is needing a lot of pain meds, they may not tolerate their tube feeds. It just really depends. And then things that you can do is you can check residuals. You can consider continuous feeds versus bolus feeds. You can try a fiber-free formula or a low-fat formula. And then making sure that the patient has prokinetic motility agents would be helpful as well. And then erythromycin and metoclopramide are also medications that can help with gastric emptying. Constipation can also be an issue. Oftentimes we hear complaints of diarrhea, but constipation can occur as well. And so you just want to look at the patient's medications. Maybe they would be causing the constipation. Do they have an obstruction? Are you providing fiber? Sometimes that gets forgotten. And then sometimes we aim on the fluid needs, and increasing free water could help resolve the constipation. Okay. So diarrhea, like I mentioned, is probably the most common complaint about tube feed formulas. You definitely want to look at medications. So magnesium and phosphorus supplements are very heavily used in the hospital setting, and they can actually cause diarrhea. Sorbitol can also be in medications, and that can cause diarrhea. Obviously, antibiotics can cause diarrhea as well, but they can also lead to bacterial overgrowth. So definitely checking for C. diff. And then sometimes even treating with prebiotics or probiotics could be helpful. Causes that could be related to tube feeds would be too rapid of a tube feed infusion, and then microbial contamination could lead to diarrhea if you're not following the guidelines for changing out a closed tube feed system, changing tubing, etc. And then other things to look at, or just like if it's a hyperosmolar formula, if they maybe have some sort of malabsorption, or potentially lactose intolerant. Okay, the other thing that is just helpful to know is about tube feed clogs. So that's another common complication, and that's usually in the inpatient setting due to nursing staff providing medications through the tube. And sometimes what they'll do is they'll crush all of the medications, mix them all up, and then put them down the tube. The best practice guidelines say that you should not mix the medications, that you should give the medications one at a time, and that you need to add water before and after giving each medication. But the best practices for removing a tube feed clog is to use warm water first, and then you put it in a syringe, and then you just do like a back and forth motion with the plunger of the syringe to see if you can dislodge the clog. In most scenarios, it's going to be the nursing staff that is going to try and get this clog out. There are also pancreatic enzymes that you can use to help dissolve the clog. You let it sit in there, and sometimes they'll just kind of break it up. And then there are also declogging kits that you can buy. So one of them is an adapter that is a little bit smaller, and so it increases the pressure in the tube as you put in the water, and sometimes that higher pressure can dislodge the clog. And then there's another one that has enzymes in it. So those are just things to know. Okay. The last part that we're going to cover is just about enteral orders. And it's important to figure out what your hospital facility will use when they're doing orders. I like this sheet because it kind of reminds you of all the things that you need to consider. So specifically, what type of formula are you going to use? How many calories, protein, We don't typically indicate the carbohydrates and fat. Usually we just indicate the calories and the protein. And then you want to indicate how you're going to give that. So which route are you going to use? And then providing the rate, the method and the rate. So is it continuous? Is it intermittent? Is it bolus? And then what's your goal rate? What is it at? And your goal rate is what? So I think those are all important considerations of the order. And then, of course, you also want to include a water flush. And so we're just going to look at what a tube feed order might look like. So we might have continuous feedings via an NG tube. We're going to provide replete with fiber at a goal rate of 60 mils an hour. A water flush of 30 mils Q4 hours. So that Q just indicates every 4 hours. And then this prescription will provide this amount of nutrition. Or we might have bolus feeds via PEG. We're going to provide 2 cartons or roughly 480 mils of formula 3 times a day, and a water flush of 60 mils before and after each bolus feed. And this is what the order will provide. Just a note on the cartons of formula, you're going to see varying, and I even flip back and forth sometimes. A carton of formula contains 240 or 250 mils of formula. They technically contain 250, but a lot of people just call it 240 so that it's a nice even 8 ounces. It's a very negligible difference, so don't get too hung up on those details. Okay. And then as far as rate initiation goes, it's really going to vary by the facility, the medical condition, tolerance rates, etc. So the rates might start at 20 to 55 mils an hour and advance by 10 to 25 mils every 4 to 24 hours depending on tolerance. Those are huge ranges for the rates as well as the hours. It's really going to be clinical practice and what the clinicians are doing at your facility. I have found that it is helpful to keep in mind that 30 mils an hour is an ounce provided over an hour. So it's a very, very small volume, like a trickle of nutrition that's provided over an hour. So when you're thinking about rate advancement, 10 mils an hour is quite small. So just keep that in mind as you're writing your orders. Okay, so a common initiation might be starting feeds at 20 mils an hour and advancing the rate by 15 mils every 4 hours until the goal rate of whatever your goal rate is reached. So when I'm writing my orders, I'll include my goal rate, and then I'll also include some sort of statement about how to initiate the feeds. As far as bolus feed initiation goes, oftentimes we're transitioning from continuous or cyclic feeds to bolus feeds. Not always, but usually we are. So you can start at their max tolerated continuous rate. So if their goal rate was 85 mils an hour, you could try starting the first bolus feed at that rate. Or if you suspect that they might have some tolerance issues, you can always start it at like 60 or somewhere around there mils, and then advance by 60 to 120 mils every 4 to 24 hours, depending on tolerance. Again, practice is, it varies heavily. It's really just going to be your best judgment. And some people may even advance by 60 mils every other feed or every feed to get the patient to their goal needs. Okay, as far as water flushes go, in the adult patient, you want to flush the feeding tube with a minimum volume of 30 mils every 4 hours during continuous feeds to prevent the tube from clogging. So that's really the minimum water flush that you need, is that 30 mils every 4 hours. And then if you're doing intermittent feeds, you do want to make sure that you do still flush that tube before and after the feeds. And typically, if you're doing bolus feeds, you want to do at least 60 mils before and after each bolus. Okay, as far as monitoring and evaluating patients go, it is facility dependent. You do need to monitor enteral nutrition daily for neonatology, so infants in the NICU, and critical care patients. And then really you just need to monitor enteral orders every 2 to 7 days for stable hospital patients. And that's kind of, that monitoring is also oftentimes when you're going to write a note on the patient. Or sometimes you're just following the patient's enteral orders and what they're getting, but you're not actually writing a note on the patient. It's really going to depend on the facility. And then longer term care or home enteral nutrition patients might be monitored every 1 to 4 weeks to start, and then less frequently if they're stable. So if the patient is a chronic tube feed patient, so if they're on it for years and years on end, they might actually just be evaluated by a dietitian once a year in the home health settings. That's pretty common. Okay, so that was enteral nutrition jammed really quickly into a lecture. And there's still certainly things that we'll cover throughout the semester on enteral nutrition, but those are the foundations for the rest of the semester.